Good morning, class. Today we are going to discuss with the topic habits. As in orthodontics, we are dealing with the malocclusions. Many of the habits are a reason for causing malocclusions. So it is a relevant portion to be covered. And habits, starting with the definition of habits, it is a tendency towards an act that has become a repeated performance, relatively fixed, consistent, and easy to perform by an individual. Habits are of different types. Many authors classified it in various ways. And one of the classification is stressful habits and non-stressful habits. Stressful habits, it's because of stress, due to the stress. For example, we usually see is nail biting, and non-stressful habit is gingival stripping. Another classification is functional or intentional, and empty or unintentional habit. Functional habit, it affects the function of our oral cavity or muscles, or which, for example, mouth breathing. It is a function we are doing regularly. Breathing is a function, and if normally it is nasal breathing, and if it is through oral cavity, it will be a habit, and it is called mouth breathing. And another function which is affected is by the tongue. Tongue thrusting, it is a functional habit. An empty habit means chin popping. It's not actually a functional habit, and it is not an intentional one. It is unintentional. Another classification by William James is useful habits and harmful habits. And Kingsley classified habits into 4, which is functional, muscular, postural, and combined. Finn and Sim classified habits into compulsive habits, non-compulsive habits, primary habits, and secondary habits. Coming to Graeber's classification, he classified habits based on etiology, and the following comes under Graeber classification, which includes thumb sucking, tongue thrusting, lip biting, mouth breathing, abnormal swallow, speech defects, postural defects, psychogenic habits like bruxism, and defective occlusal habits. Next author who classified habit into pressure habit, non-pressure habit, and biting habit, it is classified by Ernest Klein. So these are the classifications of habit. Now we will be discussing each and every habits which is relevant in our orthodontics, that means which causes severe malocclusions. The most important and most commonly seen habit which causes severe malocclusion is tongue thrusting habit. Tongue thrusting habit means we unintentionally or intentionally, maybe due to stress or maybe due to some other defects, we thrust our tongue between the upper and lower anterior teeth, and it is usually doing on 2 conditions, either doing swallowing or doing press position. So that is tongue thrusting habit, which is a condition in which tongue makes contact with any teeth anterior to the molar during swallowing, or on a resting time. Coming to the etiology, tongue thrusting, the etiology of tongue thrusting is maybe due to genetic etiology, or it is due to a learned behavior, which is why we call it as a habit, and or maybe due to some maturational defects or any mechanical restrictions which prevent the tongue in its proper place, proper position, or some neurological disturbances or some psychogenetic factors. Tongue thrusting is mainly classified commonly into simple tongue thrust and complex tongue thrust, and also it can be classified into deforming tongue thrust and non-deforming tongue thrust. Another classification of tongue thrusting which includes type 1, type 2, type 3 and type 4. Type 1 tongue thrust is non-deforming tongue thrust which causes no malocclusions due to this particular habit. Type 2 tongue thrust, it is deforming anterior tongue thrust. Tongue thrust can be of anterior tongue thrust or posterior tongue thrust. If the tongue thrust in between between the anterior teeth, it is called anterior tongue thrust, or if it is between the posterior teeth, it is called posterior tongue thrust. So type 2 is deforming anterior tongue thrust. In type 2 conditions, the tongue will thrust in between the upper and lower anterior teeth, and also it causes some minor or moderate type of malocclusions. In that, this type 2 is again classified into subgroup 1, subgroup 2 and subgroup 3. Subgroup 1 is anterior open bite, subgroup 2 is anterior proclination, subgroup 3 is posterior crossbite. So in subgroup 1, type 2 subgroup 1, we can only see an anterior tongue thrust with anterior open bite. And in type 2 subgroup 2, we can also see an anterior proclination. And of subgroup 3, we can see a posterior crossbite also due to this anterior tongue thrust. And type 3 is deforming lateral tongue thrust. Lateral tongue thrust means posterior tongue thrust. In this type, 3 other subgroups also are seen. Subgroup 1 is posterior open bite. We can see posterior open bite in that subgroup 1 type of cases. And subgroup 2, posterior crossbite, maybe along with the other features. And subgroup 3, deep overbite can be seen. And type 4 is another category which is deforming anterior and lateral tongue thrust. Both anteriorly and posteriorly tongue thrust can be seen. Here, the features of type 2 and type 3 will be seen both anteriorly and posteriorly. That means subgroup 1 is anterior and posterior open bite. Subgroup 2 is proclination of anterior teeth. Subgroup 3 is posterior crossbite. So this is a major classification of tongue thrust habit. And simple tongue thrust. Simple tongue thrust means there will be normal tooth contact, good intercuspations of the posterior teeth. Only feature is a mild anterior open bite will be seen in a simple tongue thrust, and mostly tongue thrust will be seen during swallowing time only. In the rest position, we may not be observed with the tongue thrusting. But in complex tongue thrust, the teeth apart swallowing will be seen. The normal interdigitations will not be there. An anterior open bite will be there. And during swallowing, due to the teeth apart swallow, we will not be seeing any temporal muscle constriction because the teeth are not in not coming to contact. And contraction of circumoral muscles will be seen other than besides the temporal muscle constriction. And in these complex tongue thrust, severe malocclusion like open bite, cross bite, everything will be there. Like we seen in type 3 and 4 tongue thrust. And also at the rest position, resting time also tongue will be in between the upper and lower anteriors and posteriors. So these are those were the classifications and the etiology of tongue thrusting habit. And coming to the clinical features of tongue thrusting habit, as you can see in these pictures, we already discussed in the classification. Anterior open bite will be the, posterior cross bite will be the, anterior proclination will be the. All the features are seen in tongue thrusting habit cases. So proclination of anteriors, anterior open bite, bimaxillary protrusion, posterior open bite in cases of lateral tongue thrust, and posterior cross bite. Posterior cross bite occurs due to the lower position of the tongue, which restrict the transverse growth of the upper growth of the maxilla, and which causes restriction in the transverse growth, which will leads to a posterior skeletal or maybe dental crossbite. And you can see less occlusion in posterior tongue thrusting cases. Along with this clinical feature, we can see a deep palate in such cases. So those are the major clinical features. Coming to the management of tongue thrust. Management, whichever cases of habits, management should include finding the etiology. We should talk to the patient and we should take proper history of the patient, and we should find the etiology, why the patient is having such habit. So we should talk to their parents, and if whether their development was proper, their milestones of development was proper, and also whether they get proper care during their developing growing age. All such things, because habits may be due to occur due to psychogenic factors. So we should find the etiology of the habits. And after finding the etiology, we should treat for the habit correction. That means a habit interception. Habit interception is done differently for different habits. For tongue thrusting habit, we give tongue breakers, means tongue clips or cracks for preventing the thrusting of the tongue in between the anteriors. So we restrict the tongue in its proper position by giving, as you can see in the picture, these are the tongue clips, which is incorporated in a Holey appliance. So if you place this clips will prevent the tongue to protrude or thrusting between the anteriors. So, and also muscle exercises should be provide along with this, because muscular forces will be unbalanced in such cases. So all this should be done as a first priority. After getting to our control of whichever habit is present to that patient, then we should do treatment for the malocclusion. Only then the malocclusion, only after habit correction, whichever corrections for malocclusion is done will be stable. So the treatment of malocclusion will be according to the severity or what type of malocclusion is present. If open bite is present, we can treat for the open bite by using fixed orthodontic treatment. Or proclination is there, we can go for think of the extractions and treat in a fixed orthodontic treatment. Or if the patient is in a growing stage, you can think of orthopedic appliances or functional appliances if needed. So we'll treat accordingly. Which malocclusion is present for that patient, we will treat after as a second phase or after the correction of the or interception of the habit. So that is about the tongue thrusting habit. Next is mouth breathing habit. Mouth breathing habit, as I said early, we normally breathe through nose, right? So if mouth breathing habit will occur in various different ways. If some anatomical obstruction was there, or in such cases, the treatment will be different, and if it is due to a habit, the treatment will be different. So we should assess what is the etiology of the particular habit. So in mouth breathing habit, we can see patients will be breathing through oral cavity or mouth. So as I told, the mouth breathing habit can be classified into 3 ways. That means it is also based on the etiology. Mouth breathing habit may occur due to some obstructive factors, or it may be due to habitual factor, or maybe due to anatomic. Obstructive means if the nasal airway pathway is obstructed due to some nasal polyps or adenoid enlargement. All these are obstructions for the airway pathway. So in such cases, patients are not able to breathe normally through the nose, and automatically they will tend to breathe through, they are forced to breathe through mouth. That is the obstructive mouth breathing habit. And the habitual means the patient, there will be no anatomical or any other obstructions. The patients are just breathing through mouth. That is the habitual. Anatomic, also it is also due to some anatomical defects in the pathway from nose to lungs. Any anatomic defects are there, and due to that defect, the patients are not able to breathe normally through the nose. And in such cases, in patients with this mouth breathing habit, the typical features which include, or the pathophysiology or the typical features which include lowering of jaw, because their mouth will be opened always for breathing. So their lower jaw will be lowered positioned, and the tongue position will be downward and forward, because they should open the airway through mouth. So the tongue should be also lowered, and the head will be tipping backward to get space for the intake of air. So these features are seen, you can see in this picture. the lower jaw is positioned downwards and the tongue is positioned lower, and you can see such cases the face is longer than normal face. So it is a typical feature for mouth breathing patients. A long face will be seen, and it is called as Adenoid Faces. It's a typical feature of mouth breathing patients. You can see a long narrow face with a narrow nose, nasal opening nostrils, and the nasal passage, because we are not using, those patients are not using nose for the purpose of breathing. So their airway, nasal air path will be narrowed, and you can see a short and flaccid upper lip. The upper arch will be constricted, because you can say narrow upper arch, because the tongue is positioned lowered. The transverse development of the maxilla is restricted due to the position of the tongue. And in due to, as a result of this narrow upper arch or constricted upper arch, you can see a posterior crossbite. Posterior crossbite either will be dental or skeleton. And also the face is like a mask-like face, that means expressionless face. And you can see associated proclination in the upper anteriors, flared incisors, and due to continuous intake of air through the mouth, anterior region, the gingiva in the anterior region, marginal region will be inflamed, and you can see an anterior marginal gingivitis. And also the continuous intake of air through the mouth, the salivation will be less, and you can see a dry mouth. And also obviously you can see an anterior open bite. So these are the common features you can see in patients with mouth breathing habit. And all these features, the patients with all these long face and all these features are, we call it as adenoid faces. In this picture, you can see a narrow nostrils, constrictor, V-shaped, and deep palate. It's also a feature because the arch is constricted. And upper lip will be short. Anterior open bite can be seen. And also you can see a tongue thrust associated with this mouth breathing habit, because in the anterior open bite, if a space is in between the anterior upper and lower anterior, automatically the tongue will thrust to that space. So in associated with the anterior open bite in this mouth breathing, due to this mouth breathing, the patient will later develop a tongue thrusting habit. And coming to the diagnostic part of mouth breathing habit, three methods are there. One is mirror test or fork test. Another is cotton test or butterfly test. Next one is water holding test. Mirror test. In the mirror test, we place a double-sided mirror below the nose. That means between the base of the nose and the upper lip. And patient is asked to breathe normally. If the fogging is seen in the mirror which is facing downward, that means towards the mouth, it is confirmed that the patient is breathing through oral cavity. If fogging is present in the downward positioned mirror. If fogging is present in the mirror which is facing towards the nose, you can say that the patient is a nasal breather. And in butterfly test or cotton test, ask the patient to respirate and see which direction this cotton is moving. If it is moving upwards, air will be coming out through the mouth. If it is moving downwards, that means the patient is a nasal breather. And water holding test, ask the patient to hold the water in the mouth at least for 3 minutes. If the patient is able to hold the water minimum of 3 minutes, the patient, you can see, you can say that patient is a nasal breather, means patient has no difficulty in breathing through nose. If the patient is unable to hold the water at least for 3 minutes, that means the patient can't breathe through the nose, and the patient will be having a, most probably will be having a mouth breathing habit. So these are the typical diagnostic tests for assessing the mouth breathing habit. And in between, I've said the enlargement of adenoids may be seen as an obstructive etiology for this mouth breathing habit, and it is seen in cephalometric radiographs, and you can see a restricted or reduced airway, upper airway, due to enlargement of the adenoids. This is you cannot see through clinically. The adenoids can only be visible through radiographs. So along with this diagnosis, diagnostic tools, mean tests, you should ask for the history, and you should do a clinical examination, cephalometrics for the assessment of the airway, and also rhinomanometry for the assessment of the airflow, and also nasal endoscopy to assess if any obstruction is present in the nasal cavity. Coming to the treatment, again, you should ask for or check for the obstructions, if any obstructions or anatomical problems for these patients. And if it is the, you should first go for correction of the obstruction or correction of this anatomical problem. Then only we can give any of the appliances for the correction of mouth breathing habit. Otherwise, the patient will persist the habit whatever we do for the correction of the habit. So check for any obstruction. If there is some obstructions, you should correct it by doing some surgeries, or if it is due to a nasal polyp, or if it is due to some enlarged adenoids, we should surgically remove the adenoids or polyps. Or if it is due to some any other anatomical defects, we should correct surgically, or due to or with the help of some medications, we should correct the obstructions or anatomical problems. After that, we should train the patient for breathing through nose. For training the patient breathing through nose, we can use appliances, orthodontic appliances like oral screen. And in oral screen, which is also called vestibular screen, it is a functional appliance. It helps to correct the function of the oral cavity also. And in the oral screen, we cannot blindly give oral screen to the patient, because the patient is breathing through mouth for a long time. So if we are giving an oral screen directly to patient, he or she cannot breathe properly. So the management of the oral screen is very important. We should, as a modification, we should give many halts in the initial stages, and by giving each appointments, we should close single halts, and finally the oral screen will be sealed completely, so that the patient can train their breathing pattern. You can train their nose or to train themselves to breathe through nose. So we cannot give oral screen directly without any halts. So that is the clinical management. So if the patient, when the patient comes for each appointment, for example, initially we give, for example, 10 halts in the oral screen, and we leave the patient and ask for the next appointment, and in the next appointment we seal 2 or 3 halts of that oral screen, and we leave the patient, and for next appointment again we seal 2 or 3 halts. Likewise, by few appointments we completely seal the oral screen, and by that time the patient will be trained to breathe through nose. And also we can give a ring attached to the oral screen to hold. We ask the patient to hold the ring using their lips, so that we can give a lip muscle exercise along with this oral screen. And after correction of this habit, we can go for the correction of the malocclusion. Malocclusion, we have discussed early the features of the mouth breathing habit patients. We can see open bite, cross bite, proclination, all that. Simultaneously, we correct all these malocclusion in the following appointments. So that's all about the mouth breathing habit. So these two habits are very important and commonly seen habits which causes severe malocclusion. Other habits will be discussed in the following classes. Thank you.